everyone so much for being here. Welcome to Pediatric Grand Rounds. This morning, I have the pleasure of introducing two of our amazing providers, Dr. Molly Adrian and Dr. Eileen Toohey. I'm going to introduce them both together, and then they will share this presentation and this really important topic. So I'll start with Dr. Adrian. Molly Adrian started her post-college career at Seattle Children's Hospital, which confirmed her desire to pursue graduate studies that would allow her to contribute to the health and well-being of children and adolescents. Dr. Adrian completed her graduate studies at University of Maine and her residency and fellowships here at University of Washington. Dr. Adrian is now an associate professor at the University of Washington and an attending clinical psychologist at the Division of Child and Adolescent Psychiatry here at Seattle Children's Hospital. And Dr. Eileen Toohey, who is a clinical psychologist here at Seattle Children's Hospital and UW Medicine. Her two areas of focus are the provision of effective trauma-informed treatment for youth and families in suicidal crises and the promotion of equitable access to behavioral health care. She's an acting assistant professor at the University of Washington and works in the Mood and Anxiety Program, the Crisis Care Clinic, and the Psychiatry and Behavioral Medicine Unit, or the PBMU, here at Seattle Children's Hospital. Welcome to both of you, Dr. Adrian and Dr. Toohey, and I will mute and let you take it away. Thanks so much.
Thanks so much for that warm introduction. We're delighted to be here with you all today to talk about the work that is being done here at Seattle Children's to help reduce the significant public health problem of youth suicide. So I'm Molly Adrian. I'm here with my esteemed colleague, Eileen Toohey, to discuss the evidence base for suicide prevention in healthcare settings, and then specifically outline the initiatives that are launched and being iteratively improved as part of our work to improve child health. So as Suzanne discussed, we're both child psychologists, and we're really dedicated to improving access to and impact of suicide prevention strategies in our setting. So we hope by the end of the hour that you all can define the problem of youth suicide and the role of pediatric healthcare providers in preventing this problem, understand the Zero Suicide Framework and our philosophy around least restrictive care, identify tools, strategies, and interventions in the Seattle children's setting. And we are working towards addressing two practice gaps. The first is around insufficient screening and assessment in healthcare settings, and the second is around the underutilization of brief interventions. We have no disclosures. So I'll start with some background and significance of this problem. As many of you in our audience today are aware, suicide is the second leading cause of death for youth. So this age group of 10 and up is particularly important time to focus on suicide prevention for two reasons. So the first reason is it's the time of onset for suicide risk behaviors and a huge increase in death by suicide from virtually non-existent prior to age 10 to becoming one of the leading causes of death after that. The second is that the problem of suicide is growing. So the largest increase in mortality is really in that youngest age group from 10 to 14, and a 57% increase in youth from ages 10 to 24 in over the years of 1999 to 2019. This is in the context of other health conditions really improving in morbidity and mortality. In addition to death by suicide, there are a range of self-injurious thoughts and behaviors that we consider when we think about risk for suicide. So although prediction in the near term is really not possible, the spectrum of behaviors presented here are the ones that we target for identification and treatment. The Youth Risk Behavior Surveillance System asks about some of these indicators for high schoolers and gives us some representative sample from which to understand how prevalent these behaviors are. So when youth are asked about these behaviors in the past year, about 9% of high schoolers indicate that they have had a suicide attempt or a behavior with potential for harm and intent to die. As clinicians, we also consider two other behaviors closely related to suicide attempts. So an interrupted attempt, where a person starts a self-harm behavior with intent to die and is interrupted by someone else, like a teen taking a medication and an overdose and a parent walks in and removes the medication. And we also consider aborted attempts where a person takes steps to kill themselves and then stops themselves, like making a noose, putting it around their neck, and then stopping. So these two behaviors, we don't really have good representative national prevalence data, but they're important to assess because they indicate preparation and rehearsal for suicide attempts and therefore are closely related. The yearbus also asks about non-suicidal self-injury, behaviors like cutting, burning, headbanging that occur without intent to die but do inflict harm. And in 2019, when this was assessed, about 17% of youth indicated that they engaged in this behavior at least once. The final behavior that we think about on this continuum of suicide risk is around suicidal ideation, so thinking about killing oneself. And this really ranges from normative thoughts about death and dying to active and persistent ideation. When the yearbus asks high schoolers if they've seriously considered ending their life in the past year, about 19% in 2019 indicated that they did. So overall, these behaviors are closely related to death by suicide and are much more prevalent than we would like. We also know that in COVID, youth are really struggling. So in the Seattle area, early data released by the Department of Health indicates that there's a 30% increase in death by suicide, and that about 1 in 4 youth nationally endorse suicidal ideation, seriously thinking about that. And so that's an increase from that 19% that we just discussed. So because of these reasons, as an organization, we're really taking the time to think about the programming that we need to identify suicidal thoughts and behaviors early and upstream and have just-in-time interventions that can help us prevent suicide. The overall framework that we're using to do this work is called Zero Suicide. So Zero Suicide is based in the foundational belief that suicide deaths for individuals under the care of health systems are preventable. Because we are a health system that's dedicated to improving patient safety, this practical framework guides system-wide transformation towards safer suicide care. So the core belief of Zero Suicide is when it comes to patient safety, the only acceptable number of deaths due to errors in quality of care is 0. So suicide is an aspirational answer to a really complex challenge. It emerged out of the finding that healthcare systems do not have processes in place to provide suicide safer care. And emerging data demonstrates when these quality improvement efforts that there is an impact on suicide attempts and death. And fidelity to the Zero Suicide model is associated with decreased odds ratios in an additive way. So the more that we do, the more we can prevent suicide attempts and death. So by consequence of these emerging studies, we really have the responsibility to develop processes for identifying, managing, and treating suicide risk as part of the health of the child. Additionally, there's now requirements from DNV and Joint Commission that reflect embracing principles of zero suicide, and Seattle Children's has demonstrated great commitment to embrace these principles as well. So there are 6 key strategies that guide the quality improvement efforts in Zero Suicide. 2 are around leadership and training, and 4 are around the specific processes to identify, engage, and treat youth at risk. So today, we're going to really focus on the efforts in identification, engagement, and treatment, particularly around transitions in care. So the first area I want to talk about are efforts underway to ensure that we are getting upstream in our suicide prevention efforts and identify suicidal thoughts and behaviors early in their onset. Because the majority of youth who die by suicide have healthcare contact in the prior month and almost all in the prior year, it's a really important touch point for us to assess this behavior. This is coupled with data that indicates that screening with follow-ups, including brief single session interventions, have an impact on reducing suicide attempts. So I'll provide a really brief overview of the universal screening pathway that is rolled out. It rolled out in acute care settings in 2018, so we've been doing this work for a while. All the providers here in the room who work in those settings are aware of that. And then ambulatories, clinics are rolling out as we speak. So I'll briefly discuss the process and then turn people to information about how to get more information, including like video scripts, tools, and processes. So in our universal screening efforts, we are in scope are all clinics in Washington. So youth are eligible for this screening if they are 10 and older and able to respond. And we determined that age range based on the CDC death record data, that 10 and up is when the suicide becomes the second leading cause of death. And assessing that early, while it's still a rare problem, is really important to save lives. We're asking kids to complete these questions every 30 days, and that frequency was determined because suicide risk waxes and wanes. It's pretty fluid, and so we want to be able to catch it as soon as it emerges. And all of the clinics and areas have been identifying super users and going to trainings to implement this workflow. With the transition to Epic, we are embedding these tools in the medical record to follow the zero suicide principles and help with point of care delivery. So the screening tool is the Ask Suicide questionnaire, and the follow-up is guided by the brief suicide safety assessment. A best practice advisory helps guide decision-making and connects the screening with follow-up. And there's visible indicators throughout the chart to help understand when screening is due and what to do when patients screen positively. So the ASQ was selected because it's been validated in the age range for our target population. It's been implemented successfully in peer institutions and does a better job of detecting risk than other strategies like screening for depression first. This is part of the NIMH toolkit, so there are lots of tools to help us support this work. Following the 4 questions around suicidal thoughts and behaviors, the prompts for the BSSA, that brief suicide safety assessment, is here. So you will get a best practice advisory to help guide the next steps. And if the provider wants social work, centralized social work, to do the referral, you would order that and send a message to the provider. And if the provider would like to do that brief suicide safety assessment on their own, they would not order the social work workflow. So the BSSA, that next step, is really the process to gather clinical data needed to formulate risk. So here we're thinking about the assessment of prior suicidal thoughts and behaviors and the risk and protective factors that we know are associated with suicide. So the BSSA helps us gather the clinical data around impulsivity and self-control, past suicidal behavior, stressors and precipitants, as well as engagement and alliance in healthcare. Risk formulation is definitely a complex and dynamic process, and we have thought about risk formulation really in 4 areas to help us understand an individual's risk over time. So using the clinical data from the brief suicide safety assessment, the first area we focus on is risk status. So the person's risk in relationship to the known population, your other patients that you see in that setting, whether it's inpatient psych, your patient population that you're familiar with, or the emergency department, you're making a judgment about their risk compared to your population that you know. The second area that we think carefully about is around risk state. So this person, relative to their own history and how risk is changed compared to their baseline state. The third area that we think about are available resources. So what the person has in their immediate area to activate or engage with. And then the foreseeable changes. So that fourth area is thinking about what would quickly increase a person's risk. So putting these 4 areas together helps us plan for safety and inform immediate decisions. So if foreseeable changes are likely and severe, combined with few resources being available, then we would want to have a more intensive intervention than if resources were plentiful and the foreseeable changes that would increase risk are unlikely to occur. So taken together, when we think about risk formulation in this way, it describes current, is there a question? Nope, okay. It describes current vulnerability and volatility, and it's anchored in population, time, and context. So there are many resources to help facilitate this work. So the main area to find resources around the universal screening pathway is on Child in the Zero Suicide Initiative page. So we've got job aids, the pathway, educational handouts, and there are videos and literature links to help understand why we're engaging in this work. And finally, we're hosting lots of super user trainings that all are welcome to attend. And there is an inbox, the Zero Suicide Pathway email inbox that's monitored and we will respond to. So we really want to support this work to help facilitate early identification and linkage to care as needed. I'm going to transition now to treatment, another really important area that we have some long-standing programs at Seattle Children's, and then we're also working really aggressively to build and stand up new programs that help meet the clinical need. So I'll start talking about our longest standing program, dialectical behavior therapy. So dialectical behavior therapy, or DBT, is a treatment that conceptualizes suicidal thoughts and behaviors as a response or solution to pervasive emotion dysregulation. So this pervasive emotion dysregulation, or lack of skill and motivation to respond to distress in adaptive ways, is posited to develop based on emotional sensitivity, including high levels of reactivity, slow return to baseline, combined with an invalidated environment that blocks skill development and reinforces dysfunctional behaviors. So that combination really interrupts the normative emotion regulation skill development. An individual becomes dysregulated and uses self-injury to help regulate themselves.
The puppies.
So this treatment was developed in our backyard by Marcia Linehan, Professor Emeritus now at the University of Washington. It's a comprehensive cognitive behavioral treatment that was originally developed for chronically suicidal individuals with borderline personality disorder. The treatment is called dialectic because it combines mindfulness practice with behavior therapy and has an overarching worldview that emphasizes the synthesis of opposites. So the fundamental dialectic in DBT is that between validation and change. So really focuses on accepting the person where they are within the context they are in, and really pushing for change within that acceptance. So DBT is the only well-established psychological intervention that has been replicated across two separate randomized controlled trials conducted by two separate groups of investigators for youth. And so the first work was done by Lars Mellem, and in 2014, DBT was shown to be more effective than enhanced visual care. And then the second trial was conducted here with our team, led by Elizabeth Macaulay, co-led by Marcia Linehan and Elizabeth Macaulay, published in 2018, demonstrating that DBT was more effective than individual and group supportive therapy at reducing suicide attempts at the end of treatment. However, at the 1-year follow-up, unlike Lars's study, those groups converged and there was no significant difference. And then we also published work demonstrating that youth who had higher levels of emotion dysregulation and parents who had greater levels of psychopathology and dysregulation benefited more from DBT than IGST, so demonstrating some moderation and treatment effects there. So because of the strong evidence base and expertise here at Seattle Children's, there are two programs that are available for youth who have chronic suicidality, suicide attempts, and failures of lower levels of care. So the first option is the standard outpatient DBT program, similar to what has been evaluated in the RCTs. So this multimodal treatment includes about 2.5 hours of treatment per week. So one session of individual therapy for 1 hour, 2 hours of multifamily skills group, so a parent and teen together in the group. We've also added, because of our expertise here, we've been able to add some parent-only skills group, and then youth and parents both have as-needed phone coaching. So the duration of this program is 6 months to 1 year and is really targeting those youth who have demonstrated pervasive emotion dysregulation, chronicity in their suicide risk. So really kind of a high level of care for an outpatient treatment. And because of the support of our division and hospital, we have been able to actually augment standard outpatient DBT, and the DBT team is now trialing an intensive outpatient program, which would be shorter in duration, but more intense. So it would provide 12 hours of treatment a week over a 3-month period of time. So includes the same components of individual therapy and skills training, and also augments it with more mindfulness and movement-based yoga practice, art therapy, and continues to include that phone coaching. So this is being trialed now, and I think we'll have really important outcomes to demonstrate that it's a useful program and it's really needed. So for referrals, if you're interested in referring, individuals would make a referral in EPIC to ambulatory psychiatry, do an evaluation with one of our providers who would then refer on to a DBT program. Now I'm going to turn to Eileen to discuss some of our other program that has been developed to help meet the need for new onset and suicidal crises that are emergent, as opposed to this more chronic suicide risk that we're targeting in DBT.
Thanks, Molly.
Yeah.
All right. So I'm going to talk about our crisis care clinic that we developed here at Seattle Children's. And as Molly just described, DBT is a really excellent treatment for patients who have chronic self-harm and need a more intensive level of intervention for suicidality and self-harm. It's in very high demand, and we know that we need more options for families. So we had the opportunity a couple of years ago to stand up our crisis care clinic. And the clinic was started actually thanks to an anonymous family donation. So there was a family themselves who had gone through the difficult process of dealing with mental health crises and coming kind of in and out of the emergency room, and had the experience that a lot of families have, where you know, you can receive good care in our emergency room, and then navigating the mental health system in this state is just so challenging. So this family generously gave us the funds to start up a clinic so that other families have a different experience. So these are the current goals of the Crisis Care Clinic as we've developed it over the past couple of years. We know that families who are in a new suicidal crisis need quick access to care. We know that both patients and caregivers need support, and this is something that we really emphasize in the Crisis Care Clinic. We really focus on maintaining the least restrictive level of care, and I'll talk about that a fair amount because I think it would be useful to have a conversation here about how and why it is that we sort of minimize psychiatric hospitalization as an option for suicidal patients when possible. And then again, a main goal of the Crisis Care Clinic is helping families navigate systems and get connected to ongoing care. Next slide, please. Thanks. So I'll walk through the components of treatment in our Crisis Care Clinic. As Molly mentioned, it's a much briefer intervention, so up to 4 weekly visits for both patient and caregiver. So in the CCC, the patient meets with one clinician and parents or caregivers meet with another clinician, and then we all come together and work together on safety planning and brief intervention for suicidality. We get a lot of feedback from families that the parent component is one of the things that they most appreciate, that families who are in a crisis, it is not only the patient who has needs for support and processing, and parents really get that in our clinic and are appreciative of it. We use evidence-based interventions, so the Collaborative Assessment and Management of Suicidality, or CAMS, which is a suicide-specific treatment framework to target the drivers of suicidality. So working on really identifying for this patient what are the underlying factors that drive their thoughts or behaviors around suicide, so that we can develop an ongoing treatment plan to target those drivers. I cannot emphasize enough the central role that case management plays in our clinic. It's in a lot of ways just as important as the clinical care that we provide. So we have a full-time case manager whose responsibility it is to manage our complicated triage and referral process, and then also to really handhold families as they work on finding ongoing care, including therapists and sometimes medication support. This is the other area that we get the most feedback from families about, that having somebody available who answers the phone, who understands what's going on, and can really do the hard work of finding therapists in our current environment is a big part of what makes us successful. And then the emphasis of connecting to ongoing care. We wouldn't be able to run a crisis care clinic with this brief intervention if we didn't have somebody managing that piece of helping people get connected. Next slide. So like I said, we started a little over 2 years ago, and since that time we've seen over 170 patients with a broad range of ages, 10 up to 20. Most kids we see are teenagers, so we definitely have quite a few 10, 11, and 12-year-olds. A little over half female, and then a large component of gender diverse youth who are at higher risk for suicide. I'll emphasize that the patients that we see in the Crisis Care Clinic are in a suicidal crisis. So about half of the patients we see had actually had an attempt during the month prior to seeing us. And these are patients who are all endorsing kind of the highest level of suicidality on the ASQ. So the screener that Molly talked about and that many of you are familiar with, they're endorsing that item 5 about current suicidality. Again, we get a lot of feedback from families, and they're sharing that they really appreciate and have liked the treatment that we provide, so strong feasibility and acceptability. We do see a significant decrease in suicide risk ratings on the CAMS suicide status form, which is kind of the main measure of suicidality that we use in the clinic. And then 95% of our patients are connected to ongoing care at discharge. And if you're familiar with the rates of connection to care, for example, leaving inpatient psychiatric hospitalization, this is a really high number. So really good success there with getting people connected. Next slide. We expect that people will have questions about referring to the CCC, so wanted to include a fair amount of information here about how to do that. So in the blue section there is how you make a referral to the crisis care clinic. We really encourage people to refer. We want to know what the need is, and we want to help as many families as we can. And we have limited slots and a pretty kind of tricky triage process in order to keep our clinic going as a crisis clinic. So we can't keep a wait list in order to do that, and only enroll patients who can be scheduled within a week. So if you call or reach out, Leah, our case manager, will let folks know if there currently aren't slots available. And our triage is really based on who came in that week in terms of referrals, and we prioritize the families who we think will benefit from this suicide-specific brief intervention. We've found over time that we tend to be a little bit less effective, I would say a lot less effective, for families who've been dealing with chronic suicidality or who have already been through multiple levels of mental health care, and are most effective with families who are dealing with suicidality relatively recent onset. And then within our triage process, other things being equal, we prioritize families who don't already have outpatient treatment, families who identify as BIPOC or speak a language other than English, or have Medicaid. So those families get bumped up on our triage list. I think that's everything I need to say here. It's pretty self-explanatory, but within Seattle Children's, you can place an EPIC referral. Within the ED, the MHEs have special instructions and a relationship with Leah. And from outside of Seattle Children's, you're welcome to email or call. And Leah encourages people to call if you have questions about referrals. She's happy to talk. So this last element of the Zero Suicide Framework is about transitions. And I work on the consultation liaison service, or our psych consult team, and want to talk some and kind of dig in here to some of the work that we're doing to enhance the options that we have available for families in a suicidal crisis, either on our medical floors after a suicide attempt, so patients who've been admitted for medical treatment of their suicide attempt, or families in the emergency department. I get asked a lot, you know, when is this patient going for inpatient psych treatment, or when are they going to the PBMU? And wanted to use this opportunity to talk through a little bit, again, how it is that that's not always our default response. Even after a suicide attempt, we want to think about other least restrictive options in certain cases. Next slide. Okay. So I'll walk through this slide. As we all know, we have increasing volumes of suicidal patients in our emergency department and on our medical floors. And I expect that a lot of folks in the audience today know about the increase in boarding that can happen when there's a surge, and we've definitely seen this during COVID. So patients in the emergency department or on medical floors waiting for access to inpatient psychiatric care. We know that psychiatric hospitalization is difficult to access, leading to this boarding issue. It's costly, and its benefits for suicidal patients are unknown. So there isn't good evidence demonstrating that patients with suicidality benefit from psychiatric hospitalization. In addition, there are potential negative impacts of psychiatric hospitalization, of being in a locked facility for a short period of time. And we expect that these negatives are likely increased for our BIPOC patients. I'm including this just because I think it's important to highlight some of the complexities that we consider when we're thinking about treatment and the best level of treatment for our patients who are suicidal. For many suicidal patients, brief intervention with a supportive transition to outpatient treatment is appropriate. And on our CL team or our psych consult team, we're piloting this brief intervention and case management model as an alternative to psychiatric hospitalization. And many of you all who work on the medical floors and take care of these patients have worked with us on this. Molly mentioned at the beginning Generation Reach and increased resources and focus on behavioral health in our hospital. So we have the opportunity right now to increase case management and therapeutic supports on our teams and are using this as an opportunity to enhance the care that we provide to these kids. Next slide. Okay, so I'm returning to this complex graphic, which I think does a nice job of capturing how dynamic and multifaceted evaluation of suicide risk is. Mental health providers are often asked to estimate the risk of suicide for patients, and that's actually a very challenging thing to do because it is something that is dynamic and moving and changes over time. So I'm going to highlight, as we talk about our decision-making about level of care, risk status and risk state. So the blue and yellow sections here, which really kind of translates to chronic risk factors. So the kind of ongoing factors that put a person at higher risk for suicide, things like impulsivity, depression, past experiences of trauma, prior suicidal behavior. And then risk state, which is really more about the acute current risk. So currently, what do we know about this person's suicidality that can tell us about imminent risk of suicide? So their current suicidal thinking or intent or plan. Next slide. Here we have a much simpler graphic, which seems almost ridiculously simple, but is a really helpful teaching tool when we're working with families and patients to describe how suicidal thinking works and how that informs our treatment planning, as well as developing a good, strong safety plan, which is one of the most important components of the treatment that we provide. So again, chronic suicide risk or risk status is associated with long-term risk factors. These are things like depression that require ongoing treatment. Acute suicide risk is what we're really thinking about in our emergency department and on medical floors when we're thinking about what's the next step in treatment. And that is an assessment of what is this person's current risk. And these things change over time. So acute suicide risk can really flare pretty quickly. And our job as treatment teams is to work with the family to develop a plan for how do we identify the things that for this person can spike their acute risk, and what can we do to help to notice that quickly and ameliorate the risk through a strong safety plan. Oftentimes when I meet a patient on the medical floor after a suicide attempt, their acute risk has actually passed. The acute risk was around the time of the attempt. They've been through, sometimes they've been in the PICU, they've had some time, and are feeling not acutely suicidal in that moment. And that's one of the reasons why hospitalization, psychiatric hospitalization at that point is not always necessary. Next slide. So continuing on this theme of suicide risk as a dynamic process, oftentimes in medical settings after a suicide attempt, we approach evaluations with the question, does this patient need to be admitted psychiatrically? And in many systems, there's almost sort of a default setting to yes, after a suicide attempt, that's the treatment that's recommended. We're shifting to ask, is this patient safe enough to go home yet? If not, then we want to think about what are the things that need to happen to get this patient ready enough to go home. Sometimes psychiatric hospitalization is a part of that recommendation, and other times we can provide the components of care that are necessary in a brief intervention to get patients safely home. Next slide. Distinction between does this patient need hospitalization, kind of yes or no, black or white, and is this patient safe enough to go home yet, seems like a subtle and maybe not important distinction. One of the reasons that it's really important in how we talk about our treatment planning with families is, especially
Legoland. I love Legoland.
Make sure to mute, please.
What a wonderful interruption. That was delightful. Of all the things we could hear about, Legoland is a good one. When we talk with families and teams about hospitalization, sometimes we can get stuck in the thinking that it's necessary. And especially in boarding situations, we have families waiting for days, often many days, to get a slot on the PBMU or another inpatient setting. And during that time, we have this opportunity to provide strong evidence-based care, the components of treatment that ought to be provided on the inpatient unit, and oftentimes can get families ready to transition to outpatient care. So we really want to work on our messaging to families and teams about the benefits and the limits to the benefits of hospitalization so that we have an opportunity to provide ongoing evaluation and intervention. Next slide. So back to this graphic, when we think about what are the components of treatment that need to be provided prior to discharging home, we're thinking about this green section or the available resources. So what are the things that for this individual or for this family are going to increase safety? And the things that we know increase safety are strong safety planning and lethal means restriction, as well as good coordination of care. So safety planning, when we do it in the way it ought to be done, includes some pretty thorough discussions of what are the triggers, those things that can move that person up the risk arc, and what are the coping strategies or kind of external safety strategies that can help a person to stay safe in the moment. We do pretty thorough communication between patients and their caregivers about how caregivers are going to be alerted to escalations and risk. And then lethal means restriction is about making the environment safe. So it's really about buying time between suicidal thinking and a person accessing the means that they could use to harm themselves. We know that many suicide attempts or suicides are impulsive and happen pretty quickly after the onset of suicidal thinking. So if we can ensure that lethal means like medications and firearms in particular are secured in homes, that really increases safety. And having good, honest, respectful conversations with family about this is an important part of the treatment. And then coordination with the outpatient team. So many kids who we see already have a therapist, and providing a strong, warm handoff with them is a necessary part of what we do. And then again, we have more resources coming to provide the case management, similar to what we have in the crisis care clinic, that's absolutely necessary to getting people connected. So that will be enhanced moving forward. Next slide. Okay, so to summarize here, as I think folks know, youth suicide rates continue to increase. Seattle Children's has a real recognition with Generation Reach of a need for system-wide approaches to behavioral health. This is something we're looking out for across all of our systems. We're using the Zero Suicide Framework at Seattle Children's to improve our care for suicidal patients and to identify those patients across settings. Currently at Seattle Children's, we have the DBT program for patients with more chronic suicidality, as well as the crisis care clinic for newer onset acute suicide escalations. And consistent with the Zero Suicide Framework, we are working on new quality improvement efforts, especially on our medical floors and in the emergency department, to provide good evidence-based care and appropriate transitions for these patients. So I saw at the corner of my eye that there were things happening in the chat while I was talking, but really
so much happening. Sorry, Eileen, I was a little delayed on my slide advancing because I was getting nervous about responding to all of the activity and worried we weren't going to have time. But it looks like we do have at least 10 to 15 minutes to discuss some of the goings on in the chat. So one theme is around referring to psychiatry and the challenges with getting care in our system. So the DBT program does have a wait list, and that is kind of fluid and is, triaged according to severity and need. And so, it is several months, which we understand is not acceptable for people who are at suicide risk, high risk for suicide. So we are working on that, and we've got a team of very capable folks on triage transformation to try to help us manage our limitations and get better access to our care. Okay, let's see. Okay, great. Yeah, okay.
I'll be interested in your thoughts on it too, Molly. So from Hal Quinn, what do we know about some of the interventions that we tell families while we're waiting for kids to get into treatment? So locking up medicines and knives, do people actually do that? Do kids who have made the decision to die by suicide find other ways when these things have been done? Thank you for that question. In terms of whether people actually do that, we actually looked into this recently to see whether there's any research, and I don't think there is an answer to that. Anecdotally, I've definitely had the experience of working with families who say, gosh, yeah, we didn't do those things. And my impression is that when that happens, I think there are multiple reasons for that. I think one of them is that it can be very overwhelming for families to be given sort of a blanket message of we need to make the environment entirely safe, because realistically that's impossible. And so we're working in our system on revamping the standard messaging there to really become more individualized and I think more honest and realistic with families. So specifically, medications and firearms should always be secured. Medications because they are very frequently used for suicide attempts, and firearms because they're so lethal. And that beyond that, the lethal means restriction plan with the family should be pretty individualized. So sometimes families get the message that kitchen knives and cleaners and cords and everything needs to be secured. I think that's important information for families to know about, and I think it's also fair and realistic to work with families around what are the specific things that need to be secured for this patient's specific suicide risk. That takes more time, and I think anecdotally, it's more effective in helping families to really make the changes that are useful. I would rather families secure a few highly lethal things than not secure anything at all. So there's definitely work that needs to be done in the field to figure out how do we provide that messaging in a way that leads to behavior change. And then in terms of whether kids who have made the decision to die by suicide find other ways, my understanding is that typically no. So if somebody has a thought about using a certain means and that is not available, oftentimes the crisis has passed by the time they're able to access something. Molly, we were just talking about this yesterday. Do you have more on that?
Yeah, I think, so what you're talking about is method substitution, and that is actually rarer than you would think. And part of the reason that it is less frequent than we would think is because people who are suicidal are deficient of problem solving. So in the literature, we talk about the suicidal mode, and you have cognitive constriction. You get over-focused on your plan around suicide being the solution to your answers, and you don't come up with other alternatives to help get out of this solution. So we think that's why method substitution doesn't occur as much as we believe it would. And as Eileen was highlighting, the getting time in between the suicidal crisis and the suicidal behavior is really the critical intervention that we're doing. And so by making means more difficult to access, that is a really effective way of buying time.
And I'll just add, there is a really high quality training through the Suicide Prevention and Resource Center called CALM training, C-A-L-M. It's free and it's self-driven, and it gives really good information about lethal means restriction. So I would recommend that.
I could probably throw that in the chat too.
Thank you.
Yes, Hal. So what we think about when we're doing safety planning is for every suicidal plan, there needs to be an action plan to reduce access to those means. So consistent with Eileen was saying, that we really want to focus on the individual and their plans, and then create action steps around those plans. Okay. Oh, yay. Isabel, thank you. I'm not very effective at doing multiple at once. So Isabel's put the link in the chat. Totally recommend this training to get your arms around counseling, access and lethal means. Okay. Hugo is...
I was going to highlight the question about ROIs. The answer is you can contact mental health providers without assigned ROI. Actually, I think it's true that you can, even if there's not a crisis at this point. But certainly in mental health crisis, it's appropriate to contact without a release of information.
Yep, if you are both active care providers and doing continuity of care or care coordination, no ROI is required. Okay. How do we help shift the thinking that a suicide attempt is a need for an inpatient hospitalization for any? Is there something that we can identify versus who most likely doesn't need it? Thanks, Hugo, for that thoughtful question. We are, I think that we're trying to shift our mindset towards that prevention-oriented risk formulation. That's kind of our key process in shifting from suicide attempts equals inpatient hospitalization to really evaluating what are the foreseeable changes that would increase risk and what are the available resources. We don't know at an individual level who is going to die by suicide and who isn't. So that's kind of the best framework that we have currently. Eileen, do you have anything you want to add to that?
I have too many things to add to that. I think because we think about this all the time and often are making the tough sort of decisions about who we're recommending for inpatient care. The way I describe it to families is that, you know, I tend to think of hospitalization as something that I recommend when we can't come up with another way to keep somebody safe. And that when families are equipped with good information about how to communicate about safety, and when patients are willing to engage in a safety plan, so to commit to letting somebody know if they're in a suicidal crisis, that is sort of the foundational building block for me to feel comfortable not pursuing hospitalization, even when there has been a suicide attempt. I think starting there with families is important because of, again, this sort of mindset that people can get into that hospitalization is necessary, which I think is misleading because it sometimes gives the impression that something is going to happen during psychiatric hospitalization that is really key to treatment. And the truth is that most patients in inpatient hospital settings aren't getting a lot of suicide-specific treatment. And the concerns that we have at the point that we're making the decision after the attempt tend to still exist at discharge. So our inpatient treatment teams will tell us that families are often feeling very uncomfortable at time of discharge because within what's usually a 5 to 7 day stay on the inpatient unit, many of the factors that need to be addressed haven't changed. So things, like ongoing mental health or psychosocial stressors. I could talk about this at length because I think about it a lot, but I think some of it's shifting our own mindsets and sort of shifting how we describe this as one treatment option to families, and that the essential components of suicide treatment do not have to happen on an inpatient psychiatric unit.
That's great, Eileen. I think building from that, our division director, Dr. Wissow, is asking, do you have suggestions for primary care practices, especially those with co-located behavioral health providers, to help families bridge the time until they can access higher levels of treatment? So this is a great question. There was recently a meta-analysis about brief interventions to reduce suicide risk, and definitely what the principles that Eileen is talking about building a safety plan that's personalized and detailed and kind of highlights what the person can do, the communication that's going to happen when risk is high to their parents or loved ones, and then the other more formal supports that can be reached, and how to access them and what to do, like practice calling crisis lines or locating where they're going to turn if risk is high, is really an important and effective strategy. Also, doing our lethal means restriction and really problem solving with families, and then having follow-up that can continue, even phone-based follow-up to check in on how they're doing and do problem solving around use of the safety plan, the questions they have about the removal of lethal means, and then problem solving. The linkage and care are really critical components that can help reduce risk in the short term. Eileen, anything I missed there? I'm sure lots that I missed there.
I admit I was listening to you instead of monitoring the chat well.
But anything to add for co-located behavioral health providers and primary care?
No, I think you covered it really well. I think especially the piece around safety planning and the specific individualized safety plan, I think that patients that we work with can have the experience of safety planning sometimes feeling like sort of a rote checkboxy type of experience, that because you have suicidal thinking, you need to have a safety plan, and it can become a chore. And sometimes we meet kids who have had, I've done this over and over again, it's not helpful. So I think emphasizing getting good training around honest, helpful safety planning that is specific to the individual is something that's worth investing in. It takes a bit more time than some of the safety plans that I think, can be sort of more of the checklist type of approach. But really, fundamentally, it's about getting to a conversation of, as you're having these experiences that escalate your suicide risk, how are you going to get help? And then importantly, adding the piece of bringing in the adults who are going to be the help to talk about how are you going to respond in those moments, and bring kind of everybody together to almost practice that a little bit. And I guess as I'm describing this, I'm making it sound quite laborious and time intensive. I think that can actually happen pretty quickly, but it's a thorough and important step around sort of role playing how to respond in these crisis moments. And then, as Molly said, get access to crisis supports if needed.
I totally agree with that, Eileen. I think we often have that experience, Andrew, where patients are like, I've done this, and we see their crisis prevention plan or safety plan, and it is really a laundry list of all of the potential things that could happen. And we want to move away from that to a more specific plan that outlines their internal experience, their personal cues for suicide risk increasing, the thoughts and experiences and body sensations that they have that are closely associated with suicide risk, and make it kind of different, that those experiences are the cue to use the safety plan, not like every stressor in their life. So I agree that those making it specific to their risk curve, really understanding their experience in a detailed way, and then having that communication with parents can help a little bit. But it is really challenging when they're kind of burnt out on the process.
And I know we're at time, but I'll just add that I think patients' willingness to engage in that starts with how we ask the questions. So in the assessment period, demonstrating non-judgmentalness and openness to talk about this so that the patient feels not judged and more comfortable and seen, I think helps them to engage in identifying what are those triggers, and then in really engaging in a safety planning process rather than feeling like, oh, you know, everybody's freaked out by what's going on with me, and so I have to fill out this form.
Wow, thank you so much, you two, and for everyone on the line with us for your really good questions. And this is one of the most important pieces of work that we're doing right now at Seattle Children's and in our community. So we really, really appreciate all your efforts to see as many kids in as many settings as you possibly can, and to help them through this process, whether it's inpatient, outpatient, or through their PCP. So we really, really appreciate what you're doing and look forward to even increased services as time goes on, and hopefully less of a crisis as well. So thank you everyone for being here. Thank you, Dr. Tui and Dr. Adrian especially, and we'll see you everyone next week. Thank you. Have a good day, you guys.